When you think about the plumbing in your house, you expect stability. Turn the tap, water comes out, and you never think about the pipes behind the drywall.
Until the pressure drops, something rattles in the basement, and suddenly there's water in the living room.
Right. It looks like three separate disasters, but it's one broken main line. And that's the analogy here for US healthcare.
This is the Swift Healthcare Intelligence Brief for July 20th through the 24th, 2026. Normally, it's for benefit leaders and healthcare investors.
But the useful frame for everybody is this: a bunch of policy changes, bankruptcies, and rule tweaks may look isolated, but they're acting like one chain reaction.
And the core thesis is important. Healthcare costs aren't just rising, they're being redistributed. The underlying cost of care may creep up, sure, but the big shocks, premium spikes, out-of-network bills, sudden affordability problems, happen because the old shock absorbers are failing.
So the money isn't disappearing.
No, it's migrating from weakened public payers into commercial channels.
Start with where the money is drying up. First, the Affordable Care Act marketplace. The brief points to Molina, which pushed through an average premium hike of 30%.
And enrollment fell from 655,000 members at the end of 2025 to 283,000 by the second quarter of 2026. Now Molina plans to cut another $1 billion in 2027 and retreat to 6 states.
Which raises the obvious question: if rates go up 30%, why doesn't that fix the margins?
Because of adverse selection. Molina said the problem wasn't benefit design or formulary structure, it was deterioration of the risk pool. Raise premiums that sharply, and the healthier members leave.
The people least likely to use care decide they'd rather go uninsured.
Exactly. The people who stay are the ones who really need the coverage. Expensive oncology, specialized biologics, high acuity care. So the rate hike doesn't stabilize the pool. It concentrates the most expensive patients.
Which is the insurance death spiral problem.
Right, then the insurer has two choices: raise rates again or leave the market. The brief says we're already seeing the retreat.
That's one safety net fraying. The second is Medicaid.
And this one is buried in state budget plumbing. CMS is proposing limits on provider taxes, a mechanism every state except Alaska uses.
The loop works like this: states tax providers like hospitals and nursing homes, count that as state Medicaid spending, trigger federal matching funds, then cycle the combined money back to providers to supplement low Medicaid rates.
And CMS is trying to close that loop. Federal actuaries estimate the change would pull $246 billion in federal Medicaid spending out of the system over 10 years.
On top of that, HHS paused more than $1 billion in Medicaid payments to California and Minnesota over fraud and documentation concerns.
Which signals a shift in oversight. The old approach was retrospective recovery. Pay first, audit later, claw money back if needed.
Keep the system liquid, then sort it out.
Right. The newer move is upfront withholding. Stop the money before it leaves the Treasury.
Which sounds reasonable if you're trying to stop fraud.
In theory, yes, but broad payment holds can choke cash flow for legitimate providers too. Home and community-based care groups often run on thin margins. Pause payment for a 90-day audit, and some of them go under.
So healthy people are leaving the ACA pool, and Medicaid cash flow is tightening at the same time. Hospitals and independent practices get squeezed from both sides.
And that helps explain the provider response. Community health systems reported a 20% rise in uncompensated care volume versus 2025 and projected a $50 to $75 million earnings hit tied to ACA coverage losses.
Because if patients drop marketplace coverage and still show up in the emergency room, the hospital eats it.
Then independent practices start breaking. The brief says clinics and physician groups are on pace for 14 bankruptcies this year, compared with 6 in all of 2025.
And when a practice fails, it usually gets absorbed by a hospital system or private equity.
Which means the same doctor in the same room can suddenly bill under a hospital facility-based rate that is much higher.
Same service, bigger price tag.
Exactly. And providers aren't just consolidating. The brief argues they're also weaponizing the No Surprises Act.
That law was supposed to protect patients from surprise out-of-network bills. You go to an in-network hospital, but one clinician on the case isn't in network.
So the law created independent dispute resolution, IDR, so providers and insurers could arbitrate payment without putting the patient in the middle.
But in the second half of 2025 alone, the brief says there were nearly 1.4 million federal payment disputes under the Act, up 16%.
Providers initiated 76% of them, won 85% of the time, and in 87% of decisions got awards above the median contracted rate.
So instead of a consumer shield, the argument is that this became a shadow reimbursement channel.
Because arbitrators can consider qualitative factors, not just a simple benchmark, patient complexity, provider experience, regional market dynamics, large billing organizations have learned how to flood the system with claims built around those factors.
And smaller plans and self-funded employers don't have the bandwidth to fight all of it.
Right. The brief says just 3 billing organizations drove nearly 40% of all arbitration cases.
So one part of the market goes bankrupt. Another part industrializes the billing fight.
That's the picture. And a related battle over leverage shows up in Medicare Advantage. The brief notes CMS appealing a court decision involving Clover Health star ratings.
Which sounds sleepy until you remember that a tiny rating change can swing billions in quality bonus payments.
And those bonuses fund extra zero premium benefits like dental or gym memberships, which attract seniors and strengthen plan leverage with hospitals. Lose half a star, lose the bonus, cut benefits, and members leave.
Then the center of gravity shifts again, this time toward pharmacy.
And the brief treats this as one of the biggest structural changes in the market. Pharmacy strategy isn't secondary anymore. It's driving plan design and affordability, largely because of GLP-1 demand.
The numbers are hard to ignore. 11% of US adults are now using GLP-1s for weight loss, a fourfold increase in 2 years.
And those drugs make up 11.4% of corporate annual claims. But only 36% of employers cover them.
So 1 in 5 employers are pushing workers toward flexible spending accounts or health savings accounts to buy them out of pocket.
Which creates the two-tier problem the brief is worried about. Some people get access to branded drugs. Others go hunting in the compounded peptide market.
The brief says that market is lightly regulated and expanding much faster than oversight can keep up.
Because of the shortage list loophole. When a patented drug lands on the FDA National Drug Shortage List, Sections 503A and 503B of the Food, Drug, and Cosmetic Act allow compounding pharmacies to make what is essentially a copy to meet demand.
A temporary relief valve that, according to the brief, got turned into a business model.
Exactly. The argument is that companies use the shortage window to build direct-to-consumer operations, then expanded into unregulated peptides for muscle growth and longevity.
And the concern spelled out here is minimal clinical evidence, fractured oversight, and serious liability risk for people injecting compounded products at home.
Then pharmacy gets another potential shock. The brief points to a proposed tiered tariff plan that could eventually impose a 200% tariff on generic drugs not manufactured in the United States.
Which matters because in the brief's telling, cheap offshore generics have been the main shock absorber offsetting inflation from specialty biologics. That's a major piece of the PBM math.
Generics balance the ledger. The policy goal is reshoring for national security. Fine. But the immediate risk is that offshore suppliers just leave the U.S. market rather than absorb a 200% penalty.
And if generic supply gets expensive or tight, the model supporting employer plans gets hit again.
Which brings this back to people. The brief quantifies the human effect with job lock.
According to the Gallup and West Health data it cites, nearly 25% of insured workers are staying in jobs they want to leave because they're afraid of losing coverage.
5 years ago, it was 1 in 6. Now, it's nearly 1 in 4. And among workers with medical debt, it rises to 44%.
So employer coverage becomes the thing you cling to, not because it feels generous, but because the alternatives look frightening.
Exactly. The individual market looks unstable. Employer plans absorb higher costs by shifting deductibles and premiums onto workers, which strengthens job lock, even while actual financial protection gets thinner.
And the administrative side is changing too. The Department of Labor is proposing that federally regulated ERISA plans can send key documents electronically, claim denials, COBRA notices, that kind of thing.
For large self-funded employers, that cuts printing and postage. But there's a real trade-off. A physical certified letter gets attention. An email with a cryptic attachment can vanish into spam while somebody is dealing with a denied claim or trying to keep coverage after losing a job.
So more efficiency for the employer, less clarity for the member.
That's the tension.
All right, zoom out. The ACA risk pool deteriorates. Medicaid financing tightens. Providers consolidate and use arbitration more aggressively. Pharmacy becomes central because of GLP-1s and possible generic tariffs. Workers feel trapped.
And the brief's main synthesis is that over the next 12 to 36 months, the defining trend won't be some sudden surge in utilization or a new clinical breakthrough. It'll be cost migration. As Medicaid restricts flow and ACA markets price out healthier people, the unfunded burden gets dumped onto commercial provider rates and employer-sponsored pharmacy benefits.
So again, the money isn't gone.
It's redistributed. Every premium, every prescription, every facility fee, that's where people encounter it.
And the final implication is the unsettling one. If job lock suppresses labor mobility and entrepreneurship, and more of the system's unfunded costs keep getting shifted onto employers, what happens to small businesses, independent work, and the gig economy?
Do we end up in a world where only large legacy companies can afford to employ people because only they have balance sheets big enough to absorb the failures of the rest of the healthcare system?
Not a cheerful thought.
No, but it is the hidden mechanism this brief wants people to see.
Keep asking hard questions.
And keep looking behind the drywall.
We'll catch you next time.